Well, thanks so much for joining me today for the fourth episode of Season 4 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. I want to begin by again acknowledging and thanking Scan Health Plan for supporting the Healthy Skeptic MD podcast. It is very much appreciated. My guest today is Dr. Mark Schuster, the founding dean and CEO of the Kaiser Permanente Bernard J. Tyson School of Medicine here in Southern California. This is a new medical school that launched just this past year in the fall of 2020. Dr. Schuster is going to be talking to us about training doctors of the future. I truly can't think of a better, more qualified person to do this. Dr. Schuster is one of the most respected academic pediatricians in the country. He's written a couple books, hundreds of research articles. He's an elected member of the National Academy of Medicine, also who was ranked by Modern Healthcare as one of the most 100 influential healthcare leaders in the country. So some really great credentials. And on top of all that, he's an extremely nice and humble person. And I know he has some very interesting things to say. So please do stick around for that. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever it is you listen to podcasts. Search for Healthy Skeptic MD on YouTube. Pass it along to friends, family, and others who might be interested. And if you do have a chance, please do consider leaving a review. So before we jump into our interview today with Dr. Schuster, we'll start with a rundown of the health news of the week. And the first item I want to touch on is a topic that we discussed in the second episode of this season with Dr. Jason Karlawish, and that was the FDA's recent approval of the first new medication for treating dementia in a couple decades, aducanumab, or Aduhelm as it's called. And as you may recall, Dr. Karlawish and I were both critical of the FDA's decision because the data supporting its benefits in improving memory and outcomes in those with dementia is actually quite flimsy. And this would be alarming in its own right, but it was coupled with the fact that the annual price tag of this medication is $56,000 a year. So if you multiply that times the 6 million people in the United States who have dementia, that's a lot of money that is being diverted to a medication with really uncertain benefits and away from things that are much more evidence-based and important, such as social services for this population. So the FDA, to its credit, truly took heed of these critiques and did something very unusual. This week, they partially walked back their decision, and they've now limited the approval of this medication only to those with mild dementia, which were those who were studied in the actual trials that have been published so far. So this is certainly a very good step in the right direction, but even in those patients with mild dementia, the benefits are quite modest and there's some serious side effects. And before this expensive new medication becomes widely used, I do hope there are longer and more rigorous studies to assess its benefits. So this will certainly be an interesting area to follow, particularly since aducanumab is a very interesting medication that does prevent the formation of those plaques in patients with dementia. So it would be very interesting science, but we really do need the clinical data on it. So the second news item I want to mention this week is a new study in JAMA Internal Medicine looking at the issue of patient experience or patient satisfaction surveys. So we doctors are notorious for disliking patient experience, patient satisfaction surveys. We don't like being graded by our patients in this way. And one of the common critiques is that it might incentivize bad care. So if you have a patient with diabetes, maybe you would give them cookies to improve your patient satisfaction ratings, or more realistically, maybe you'd be more likely to give antibiotics or opioid pain medications. So the analysis this week reassuringly did not find any evidence of that. In fact, if anything, it suggested that that doctors with higher patient satisfaction scores actually were providing better care than their counterparts. And I was actually very happy to see this. I've never agreed with my colleagues on this topic. I believe that our healthcare system does not do a very good job of meeting our patients' needs and expectations, and patient satisfaction surveys are one of the best ways to hold us doctors accountable to that. So I was very reassured, and I do hope these will become an increasingly important quality metric in the years ahead. So the final item I want to touch on today is also another JAMA Internal Medicine study looking at the COVID-19 response in Taiwan. So as many of you know, Taiwan was one of the countries that has done the best during this pandemic in terms of infection rates and mortality rates. And the analysis tried to tease apart which components of Taiwan's response were challenge response were most responsible for its success? And perhaps not surprisingly, the short answer is it was multiple interventions, masking, social distancing, testing, and contact tracing all coming together and being done effectively. But the study did suggest that it was the simple things, the masking and the social distancing, and less so the testing and the contact tracing that really made the biggest differences here. So I think this is a really important analysis. My takeaways anyway are, first, as is so often the case, it's the simple things in healthcare that make the most difference. And the second thing is that this pandemic was not an easy thing to handle, and it really did take many important things coming together correctly to handle it well. And it's perhaps no surprise that many countries, including the United States, did not do this effectively. So that's it for the news summary for the week. Let's jump into our interview with Dr. Mark Schuster. Well, welcome to the Healthy Skeptic MD, Dr. Mark Schuster.
Hi, thank you for having me.
And if you could just begin by telling us a little bit about the formation of this medical school, because this is your second year.
That's right. We welcomed our first class last summer. And so we are new. We are based in Pasadena, California, and we have 50 students per class. And we, I would say we're a school that is focused first and foremost on medical education. Our approach is, it's not a lecture-based curriculum, it's case-based, it's small group learning, groups of 8 students and 2 faculty is our the center of our model, although we have also 6 students and 1 faculty member. We bring the students into the clinical setting starting in the 3rd week. So we really get them in there and get them understanding the importance of what they're learning in the classroom, because they're working with patients and see the relevance of biochemistry and anatomy and physiology. We also are a school that recognizes that there's a lot of burnout and depression among medical students in the United States. And so we are trying to really focus on health and well-being of our students and faculty and staff so that they can provide the best care to their future patients. And the last thing I'll say is principles of equity, inclusion, and diversity are very important to our school. They're built into our mission and vision. And we've also put a lot of effort into weaving those principles throughout the school.
Well, I want to come back to many of the things that you just spoke about, but most medical schools are based at universities, and Kaiser Permanente is a health system. Why is it that a health system would fund or sponsor a medical school?
Well, I think it's a great setting for a medical school. Our students get to learn in an integrated healthcare system, and what a remarkable place to learn. They're learning in a place that emphasizes patient-centered care and community and population health and team-based care, so that they're learning to work with on teams with nurses and pharmacists and social workers and others, and they all work together. Our students learn that each profession has its own set of skills and its own area to focus on, so that everyone can work as a team as opposed to in a more conflictual approach. And I'd also say that the reason that Kaiser Permanente started a medical school, as I understand it, was that they felt that they were having medical students from other schools come. They've come for years, having residents here. They've had residents since 1955, and they also hire new physicians every year. And they were finding that they were often retraining people. They were finding that the physicians they hired often hadn't learned about patient-centered care and quality improvement and community and population health. And so they really felt like there's something special going on at Kaiser Permanente, and that it would make sense to teach medical students right from the beginning.
Well, I really agree with you that an integrated health system is a great setting for a medical school. University set medical schools are great at teaching the basics and pathophysiology and medications, but if they don't have a good functioning health system, that's something that you're going to have to learn after your medical training, that health system science that's now part of the American Medical Association's recommendations for curriculum for medical students. that's what you guys are at Kaiser. So students are really immersed in it. Could you tell us a little bit about the curriculum at Kaiser?
Yeah, I'd be happy to. So traditionally, medical schools emphasize biomedical science, anatomy, physiology, biochemistry, and then clinical science, which is really how to diagnose and treat, hopefully how to prevent, although that doesn't always get much attention. And we have added a third pillar. It's the one you mentioned, health system science. The AMA has really taken the lead in developing that field, and it includes quality and safety, healthcare and social systems, which includes health economics, community and population health, which includes social determinants of health, or what we like to call it, social, economic, and environmental factors that affect health. Also inquiry, which is really thinking about research, health information technology, and ethics. So we've brought all those in to our third pillar, and so we don't have a separate biochemistry class and then a separate anatomy class. We teach everything together in all three of these pillars together. So say it's you're studying cardiovascular, you're going to learn about the physiology and anatomy of the heart and the vessels, and you're also going to learn about the clinical implications of cardiovascular disease and how to diagnose and treat. But you're going to go a bit further. When they say they're going to write a prescription for a particular antihypertensive medication, we want them to think to ask the patient whether they have a copay, whether they're going to be filling the prescription, and if they've been taking it for a while, find out if they actually take the pill every day or if they're stretching it out, a pill every other day, hoping to save money, which of course is not something. Saving money is great. Taking your antihypertensive every other day is not. And if our students say that they're going to recommend that their patient exercise more, then do they talk to their patient about whether they have opportunities to exercise and how they're thinking about doing it? And if the patient says, I'd love to go for a run after work, but I don't feel safe in my neighborhood, then explore, are there things they can do in their home? But also, is there a park down the street? And if there were lights in the park, might they be able to go for a run there? And other people would be running. People would be walking their dogs, strolling their babies, playing basketball. It could become a real community resource if only there were lights in the park. And you might jump in and help. You've got an MD at the end of your name, and you can get through to Parks and Recreation. You can get through to your city councilor and really work on thinking, I want to take care of my patient. I want to work with them on their health. And one way to do that is to look outside of the clinical system, outside of the prescription I write, and think about the total health of the patient. And if you actually can get lights into that park, you can make a difference not only for your patient, but for the whole community. And that's part of what we're teaching. We want our students to be advocates for their patients and their communities. And the last thing I'll say about that is that Kaiser Permanente, or any large group practice, has the capacity to have folks on board who can help with that kind of community outreach. And we're really lucky here that there are people who are really skilled in helping our physicians and our other clinicians make those kind of community connections.
So this is a really nice tie-in to the next question I have, which is that in the United States, we spend, in many cases, more than double what many other industrialized countries do on healthcare, and yet our health outcomes are not as good, and in some cases worse than many of the other countries. And one of the potential explanations for this is that we don't function like a system. We don't provide the holistic perspective on health that you're describing. How is Kaiser trying to change this so that the doctors of the future will practice in a higher value, more holistic way?
Well, we do teach about the healthcare system. Our students will leave here understanding how the system works and how different entities within that system function and what are the strengths and weaknesses. They'll understand costs. They'll understand the incentives that lead to higher costs, but as you say, not necessarily better outcomes, or at times even worse outcomes. we are teaching them how to interpret research, how to read the clinical literature, and how to assess new technology, new medications, how to go beyond what they might see in ads to really decide whether they should be integrating a new and much more expensive medication into their practice, or whether they should wait for a few more studies to decide whether this is a good medication. I would also say that our students will learn to understand the importance of non-clinical factors that affect health and what a difference social and community supports can make. There can be real cost implications there, but even more importantly, health outcome implications.
Well, it's humbling for us doctors, but as you pointed out, there's a lot of things that influence health, not just medical care. In fact, it's estimated that medical care may only be responsible for 10 or 20% of health. So if we really want to, move the needle on those health outcomes, we probably are going to have to go beyond the standard medical care that we traditionally teach in medical schools. So Dr. Schuster, one of the themes of this podcast is overuse of unnecessary services in healthcare. So there's dozens and dozens of them. We do too many back surgeries. We do too many knee arthroscopies that don't help people. We use medications when lifestyle approaches would work just as well. Is Kaiser thinking about how to address this issue of overuse?
Well, we're trying. And the first step is we teach the students about the whole concept of overuse, which I'm not sure most of us in medicine have ever formally learned. But the idea that more tests and more treatments are not necessarily leading to better health and can lead to worse health. They can cause harm to patients and they raise costs. And it's not like our patients are choosing between going on, a vacation to Paris and getting healthcare. They're choosing between food and healthcare, and rent and heat and healthcare. So many people are making those kinds of choices. So needlessly, inappropriately expensive healthcare is really challenging our patients and our whole system. And our students also are learning how to assess therapies and technologies. I guess I really referenced that before, but that matters in terms of overuse. How to determine if a treatment really is effective, if it really is going to be a good treatment, whether a certain diagnostic test is even needed, or whether there are cheaper tests that are just as good or at times even better. And we also want our students to learn how to communicate with patients about their options. And that very importantly includes helping our students understand that their patients are the decision makers and that we are there to support them in making the best decisions for themselves, and that we need to be sharing what the options are and the pros and cons and help our patients think that through. But that also includes helping our patients understand when a treatment that they've read about online may be unnecessary or actually potentially harmful. The classic example is prescribing antibiotics for a viral upper respiratory infection. And when you talk to your friends or you read online, you learn, I need antibiotics. And it's our job to explain that the antibiotics won't be helpful in a particular situation. The one other thing I'll mention is that KP, a strength of it is it has evidence-based guidelines that it develops very carefully to help our physicians and other clinicians and our medical students think through what's the best care for a particular patient. And there are resource stewardship programs that provide what's called decision support for helping physicians. I mean, you can't learn everything. You can't know every treatment for every condition. And these are supports that help physicians know if they're ordering a test that we now have evidence is not as good as we used to think it was.
Well, I think the fact that there's a component of your curriculum that has to do with overuse is noteworthy, because I don't recall that being emphasized hardly at all when I was in medical school. And I think that may be partially a reflection of the fact that you are within a health system, a system like Kaiser that's done so much to focus on protocols and not doing wasteful services. So I do think that that's another advantage of working within a real world health system.
Absolutely. We are very lucky to be at a school that is, as you said, sponsored by and funded by our parents, Kaiser Permanente.
So the Healthy Skeptic MD recently began being funded by SCAN Health Plan, which is a Medicare plan, not-for-profit Medicare plan that focuses on frail older adults. And we have changing demographics in the country, in this country, an aging population. Your graduates are probably going to need to care for more and more older patients than any of us have had to so far. I think partially what you said before about patients driving decisions is so important for older care, because goals of care are really what matter.
Absolutely. That is so important, and I'm glad you mentioned it. It's what's best for that patient, and that's going to vary from the patient you see in the morning to the patient you happen to see that afternoon. They're each individuals.
That's right. Well, let me shift gears a little bit. You've been your first year at Kaiser Permanente School of Medicine. You were in the middle of a worldwide pandemic. What was it like to start a medical school during this time?
Well, it was certainly not what we expected.
You didn't plan this coming in, I take it.
We did not plan. We had a lot of contingency plans for if there was an earthquake that brought down our new medical education building and other natural disasters, but we did not think through the possibility of a pandemic, and a pandemic that has had tragic impact around the world, including locally. But what I'd say is that we have an amazing group of people here, and we had selected and admitted an amazing group of students. And from my view, everyone rose to the occasion. We had a decision to make, back before we opened. Would we open in person or would we go virtual? And we spoke to a lot of deans and medical educators from around the country, and they strongly advised that if we could be in person, we should be in person, that virtual just wasn't as good. And I recognize that in the future, we've learned a huge amount about virtual education the past year, and virtual will be a part of our lives and better. But certainly a year ago, the feeling was that virtual was inferior. And we have a hybrid approach. Our students were learning how to take a history virtually so that they could see facial expressions with our standardized patients who are actors who learn how to play the role of a particular patient. And so we definitely used some virtual learning, but we did it primarily in person, and that allowed our students to get to know each other. It allowed for hallway conversations, questions of the teachers before and after class, or knocking on the door in the afternoon to see if you could ask a quick question. All of that's really important.
So I know a lot of the medical textbooks are starting to incorporate COVID-19 in the textbook. Is your medical school starting to incorporate teaching on COVID-19 as a disease into the curriculum?
Yeah. Well, I mean, we did, and we will continue to. Of course, we always taught about coronaviruses, but with COVID-19, suddenly it was much more interesting to our students rather than just being one more thing they were learning. And we did integrate in prevention, diagnosis, and treatment. But we went further than that. We talked about health system science, and we have a lot of teaching about health disparities, but we were able to integrate COVID-19 because students were seeing playing out in front of them in the news the disparities in diagnosis and treatment and outcomes based on race and ethnicity and ancestry and socioeconomic status, level of resources. And that was really powerful. We also were able to bring in COVID-19 when we were talking about vaccine hesitancy and also vaccine distributions and the ethics of vaccines and new treatments in general. who gets them first and who doesn't. And it also brought home contact tracing and public health surveillance. Also, COVID-19 gave us immediate examples so that we weren't just giving historical examples, but ones that were playing out in front of them.
So along those lines, traditionally you want doctors who are very good in the pathophysiology of disease and know what treatments to provide at the right time. What skills do you hope your students will have when they graduate that will allow them to practice medicine in the decades ahead that maybe are different from what historically has been expected of doctors?
So we, of course, want them to be outstanding clinicians, but as I've already suggested, we want them to be advocates for their patients and for communities. And we want them to be lifelong learners. The approach we're taking to education, where it's flipped classrooms, they watch videos in advance, they read materials in advance. They don't come to a lecture, they come to a group where they're working with classmates and solving problems. We want them to learn how to be problem solvers. Well, what they learn first year of med school, a lot of it will be out of date by the time they graduate, or certainly by the time they're out of residency. So we want them to be able to assess new technology, assess new, diagnostic or treatment technology, and assess new therapies. And that we want them to embrace change and look forward to it and be excited by it because they know that it makes a difference for their patients rather than fear it and be frustrated by it. The one more thing I'll say is med students come into medical school often excited and idealistic, and they have this spirit that is so wonderful. And I'd say our first class and now our second class are compassionate and aware of what's going on in the world around them, committed to health equity, and just smart and really eager to learn. And they've got a certain enthusiasm that's wonderful. But often by the time students graduate from med school, they've lost that specialness. That spirit has been beaten down. They leave cynical and despondent. And we want them to leave here with that same specialness, that same spirit, that same curiosity and excitement that they entered with.
Well, that's great to hear because that's certainly something that I've observed too from medical trainees, that they come out of medical training not quite the same person they went into it, and not always in the best ways. And probably that's true for all of us. But if there's a way to keep that idealism that they came in with at the start, I think that it's really good for the health of our populations in the years ahead. So Dr. Schuster, my last question is, one of the silver linings of the pandemic is that it has regenerated enthusiasm for healthcare professionals. I believe that this is one of the biggest applicant years for health professionals compared to prior years. What advice would you give to someone who's exploring a career in medicine or a healthcare field?
I would say, I'd say a few things. First, I'd say, get to know your patients, listen to them, learn from them how challenges in their lives are affecting them and their health, their mental and physical health, and what's going on in their home, in their workplace or school, in their community, or what's going on in the larger society that is affecting them. This has been a very tumultuous year, and it is affecting many people deeply. The various examples of racism in our country, which of course have been around for centuries, but are getting more attention in the past year against various groups, particularly anti-Black racism, but other groups as well. And what I'd say is, these things are affecting our patients, and it's important for our students to get to know the whole patient and to understand what will influence their health beyond just something you can diagnose quickly. We have such capacity in this country with such remarkable technology and medications. Well, the idea that we have vaccines so quickly is amazing, but also not everyone has access to getting the vaccine or other treatments. And even if they have health insurance, not everyone feels comfortable using the healthcare system, going to doctors, opening up to doctors about what's really going on in their lives. A woman may come in with some, vague abdominal pain that never really gets diagnosed as anything. But do we take the time to build a trusting relationship where she shares that she is being abused at home? There's just such an importance for our students to learn to really get to know their patients and build the kind of relationships where they can be the best doctors they can be for their patients. And then I'd also advise incoming students to attend to their own health, to think about what their needs are, and to, particularly in the context of a pandemic where people aren't even being able to connect as much, when students move to a new city to go to med school, and usually they would get to know people, but in the pandemic, it's a lot harder, and they fortunately have their classmates and the others at the medical school, and maybe others if there are adjacent schools. But still, there's a real loss, and I think that the pandemic has highlighted the need to stay connected to those we love, those we care about, and to do whatever is right for us to maintain our health, whether that's exercise, whether that's reading a book, whether that's meditating, whatever those things are that we have learned about that work for us, or learn new techniques. Certainly at our school, we are trying to teach our students a wide variety of ways of maintaining their own health. And then, the last thing I'll say is really something we already talked about, but to hold on to that passion that brought them to med school. It's a lot of work to get to go to med school. They've really tried hard to get here, and whatever it is that drove them, write themselves a letter so they can reread it in a few years, but to hold on to who they are now and to embrace changes in themselves, but also to not forget who they are and what motivated them, and to be able to look back and remember who they were when they entered med school, and to learn from that as they move on throughout their careers.
It also seems if they do items 1 and 2 that you suggested, they take care of themselves and they stay connected with their patients, it's going to keep that idealism in them and why they came to med school. So they kind of play off each other, those 3 recommendations.
I sure hope so. That's the idea.
Well, Dr. Schuster, I so appreciate your joining me today. Sounds like Kaiser Permanente is doing some really interesting things, innovative things in medical education, and we certainly need it with the population health challenges we have in the year ahead. So thanks for joining me today for the Healthy Skeptic MD. If you liked what you heard today, please pass it along to friends, family, and others who might be interested. Look on YouTube for us, leave a review if you have a chance, and we'll pick it up again in 2 weeks. Have a good day.